So welcome to the session, everyone. My name's Chris Lawlor. I'm a Regional Liaison Advisor at the GMC, and I'll talk a bit about my role over the next couple of slides, but I'm really just going to concentrate on some of the key areas that we've got in place to try and help and support medical students. So we're going to talk about good medical practice. We're going to talk about protecting patient safety and also going to touch on professionalism. So going to talk about some of the guidance that we've got in place, and then we will get on to some case studies. So feel free to ask any questions as we go through the session. I do want it to be as open as possible. It's important that you get the most out of the session. So if you have any questions that aren't about the slides that I am showing, feel free to ask them, and we can get sidetracked by those questions and discuss anything that's useful to you, really. So I'll keep an eye on the questions as they come through, and ask away, really. So we're going to do a quick recap of our standards and the standards that apply to medical students, and then we're just going to look at some scenarios, really, and look at some useful resources that we've got available that can hopefully help you in your preparation for your SJTs. So we'll run through them, and I will be asking you questions as we go, so hopefully you'll be able to get involved and give me some answers. So just quickly want to explain my role at the GMC first and foremost. So I'm a Regional Liaison Advisor at the GMC, and my role at the GMC really is to come out and talk with medical students, talk with doctors of all different levels, and just really improve the profession's understanding and awareness of the GMC guidance. But most importantly, I think to just be somebody who you can ask questions of your regulator. So holding sessions like this, you can ask whatever questions you may have. Usually these types of sessions would be run in a face-to-face room, and we would be able to interact much better than we can in the virtual world. But since the pandemic took over back in March, we've been doing as much as we can virtually to try and support the profession as best as possible. Prior to March, I would usually be out 3 or 4 days a week delivering sessions at medical schools or hospitals around the northwest of England. So my region is up in the northwest. I'm based not far outside of Manchester city centre. Do have colleagues spread all over the country in all of the devolved nations as well. So wherever you go to medical school, wherever you continue your career, you should have somebody from the GMC in that region who is able to provide some support and talk to you around issues such as this. Just want to focus on the key areas of the GMC's role, really. So first and foremost, and most importantly, I think, for you as a group here, if you are medical students or you are thinking about becoming medical students, then we are responsible for the standards in terms of your education and training. So whatever medical school you may go to, we set the standards that medical school must be delivering in terms of your education and training. So what that means in reality is, wherever you go to medical school, whether that be up in Glasgow, down in Southampton, Birmingham, Manchester, over in Cardiff, whichever medical school you choose to go to, you should be receiving the same level of experience in terms of your training and education. And what that means is, when you graduate, you should all be at a similar level and ready to start your foundation year 1 training. So important that you're aware of that role, I think, now more than ever, because we are in the middle of the pandemic and we know that it's affecting the experience that medical students and doctors in training are having. So if you have any serious concerns about the experience that you are receiving, then ultimately you can come to the GMC and you can talk to us about those issues, and we may be able to help or support you and try and resolve those issues for you. So also responsible for postgraduate education and training standards. So once you have completed med school and you enter a training program, we have the same role for doctors in training. So again, just bear that in mind, particularly as we progress through the next 3 or 4 months that are likely to be extremely difficult. If you do feel that you are being unfairly impacted, then please do speak to us. We also hold the medical register, so any doctors who want to work in the UK have to go through the registration process and have to join the register. Just quickly ask you, how many doctors do you think are on the register? Anyone want to hazard a guess of how many doctors are currently on the GMC register? Anyone on the chat want to guess how many doctors there might be? 15 million. That would make the NHS run much more smoothly than it does. That would be ideal, I think. But we've got 5,000. Is that 100,000? So the actual number of doctors on the GMC register at the moment are 330,000, just over that number. So 330,000 doctors on the register. Quite a large number, I think, but we recognise we need more doctors. If you've been into the NHS, if you've been on placements, if you work in the NHS, there are gaps in the rotas, and we recognise and are trying to increase the number of doctors on the register. We also have responsibility for revalidation, something that was introduced a number of years ago now, but doctors every 5 years have to revalidate and basically prove that you still have the skills and experience and the knowledge to retain a license to practice and work within in the UK. We are then responsible at the bottom, so the upside down piece of the jigsaw, for fitness to practice, and that's the most high profile area of the GMC's work, and don't want to focus on it too much because we would likely get sidetracked discussing that, but lots of information on our website about that, and lots of data that you can look at in terms of our fitness to practice processes. And then in the middle, we have our standards that underpin all of the other work that we do. And that's what I'm going to talk about for a bit of today, just about the standards that we have in place. Here's a selection of them. So a number of different pieces of guidance that you can see on the website here that relate to all doctors. First and foremost, if we look at the one right in the middle, which is around good medical practice. So that is our key piece of guidance, and that filters down to achieving good medical practice, which relates to medical students. And I'm going to talk about that in a couple of slides' time, but some key areas there around confidentiality and consent, some of the supportive guidance underneath that may be useful around doctors' use of social media, and the use of intimate examinations and chaperones. So lots of guidance available there to help and support students and doctors. So just want to think about now, and again, just get you all involved. What do we think makes a good doctor? What skills do we expect? What behaviours? What traits make up a good doctor? So what words and phrases would come to mind? Any thoughts on what makes a good doctor? So empathy, yeah, I think empathy is key. Communication, attention and care, some really good points. Patience, I think, is a really good point. Knowledge, attention to detail, open mindset, some really good points there that we're coming up with. So if we put a patient together, we think first and foremost, and if you go and read Good Medical Practice, the very first line of Good Medical Practice says that good doctors make the care of their patient their first concern. So I think putting patients first is absolutely key. Some good points coming through there around teamwork and good time management, absolutely. So we think that a good doctor is competent, and I'm sure if any of us at any point in our lives are patients, we would be hoping to be treated by a competent doctor. And I think actually we probably take that for granted. I think when we go and see the doctor, I certainly, from my own personal perspective, take for granted that I am seeing a competent doctor who has keeps their knowledge and skills up to date. So we've got works well with patients and colleagues. So we're thinking team working, and I think that comes down to communication as well, and working with your patients. So it takes time, takes prompt action if they feel patient safety is compromised, and then is honest, trustworthy, and acts with integrity and within the law. So just a high level thoughts about what makes a good doctor, and all of those points then link in to our key guidance, and this is where we relate the guidance specifically to you as medical students or prospective medical students. So this is our key piece of guidance that relates to students, and it's around achieving good medical practice. So it links very closely to our key piece of guidance for all doctors, which is good medical practice. And we introduced this a number of years ago now because actually we think it's really important that we start preparing students for the expectations that will be on you once you are fully qualified and once you join the register and you start treating patients. Don't suddenly want you to start on your first day as an F1 and realize there is a whole host of GMC guidance that relates to your roles. So we've introduced this guidance to help prepare you and help you understand the key aspects of being a good doctor, really. And what we do is we break achieving good medical practice down into the 4 key domains that we've got on the right hand side of the slide there. And these are the exact 4 domains that are within good medical practice. So first and foremost, I think as you would expect, we've got knowledge, skills and performance. And as we looked at for what makes a good doctor, we want a doctor who's got, keeping their knowledge and skills up to date, to is a competent doctor, really. We've then got safety and quality, and we expect that all doctors are ensuring they are working to the highest standards, the highest level of quality, and are reporting any concerns they might have about patient safety. We go on to the one underneath that. We've got maintaining trust, and that is absolutely key for when you qualify as a doctor, when you join the register. Maintaining that trust in the profession is vital. It's so important that patients trust doctors, and when they come and see you, they share information with you and they tell you things that they've never told anybody else because they have that high level of trust in you. And then finally, actually the most detailed domain in terms of achieving good medical practice, and that's around communication, partnership and teamwork, and that covers a number of the points that you've mentioned in the chat area. So about that communication with your patients, communication with your team, working together and just having that ability to work as part of a team and in partnership with your colleagues and also with your patients. So If you're a medical student and you're looking at this slide and you don't recognize this guidance and you don't recognize the domains here, then I would really encourage you to go away and just have a think about this guidance. Find it on our website and just have a brief read of it. I never expect that any doctor I talk to is reading GMC guidance on a day-to-day basis, but I think it is important that you are aware of the guidance and understand the key aspects of the guidance. So what we're going to do now is really just look through some different scenarios and just going to talk through how you would manage these scenarios, what you think is the best thing to do in these types of situations. So these are scenarios that are available on our website, and you can look at different ones and go into different detail and carry out some quick assessments to test your knowledge and understanding. So let's think the first one here. We've got Dr. Sharma has recently been appointed a consultant physician based in the stroke unit of the General District Hospital, where she was previously a specialist registrar. She witnesses a number of incidents on the unit where patients are not receiving basic care and has to decide how to act. As she is leaving the ward, on her way to see another patient, she notices that Mr. Johnson, who was transferred from intensive care 2 days ago, hasn't touched his food or drink, and she stops to talk to him. Now, what do we think Dr. Sharma should do in this situation? I'm going to give you some options there. What do we think in this type of scenario that Dr. Sharma should be doing? Should she ask Mr. Johnson what he needs, what help he needs to eat his breakfast and then feed him? Should she report the problem to the nurse in charge of the unit? Should she reassure Mr. Johnson that the nursing staff will come and help him and then leave the ward, planning to check on Mr. Johnson again later? Or should she find a nurse and ask them to help Mr. Johnson eat his breakfast? So what do we think there? So 2 different answers already. We've got a D perhaps, or an A. What does everybody else think? A and then B. Anybody else got another for D? So we said you wouldn't want to pass on the possibility straight away, so that's why we've gone for A. So you're taking responsibility in that scenario, we think. Actually, could it be all of them? Yeah, I think perhaps that there are different options that we've got here, aren't there? So let's think about them. I think the answers that we would be looking for here, first and foremost, would be for option A or option B. So we need to ensure that the patient is being looked after and treated in the best way possible. So it's vital that Mr. Johnson is eating his breakfast and is able to do so in order to keep his strength up and hopefully make a recovery. So I think certainly we'd be thinking A or D in this scenario. So we would either be taking responsibility ourselves, and if we've got the time, we might just spend the time, helping Mr. Johnson eat his breakfast by feeding him or providing the support he needs. So we're going to take responsibility that way. Or, as the case may be, I would imagine we said Dr. Sharma was in a bit of a rush. Doctors are all extremely busy. So it might be that we need to go with option D, and we want to find a nurse, and we want to make sure that the nurse is coming to help Mr. Johnson. So not just a case of reporting. We don't just want to report the problem. So if we went for option B of just reporting the problem, we can't be sure that somebody is going to come and look after Mr. Johnson and make sure that he can eat his breakfast. So if we haven't got time to resolve the issue ourselves, I think we want to be taking responsibility and ensuring that a nurse is coming and taking over from you and helping Mr. Johnson eat his breakfast. If we went for option A and we did help Mr. Johnson, then I think we would want to go for option B, and we would want to then follow that up. So if we help Mr. Johnson eat his breakfast, we'd then want to follow that up by reporting the problem to the nurse in charge, making sure that they were aware that there was a patient who couldn't eat his breakfast and was potentially being put at risk of harm. So we do want to be following it up and reporting those issues. I think we would only really be looking at option C, if we were going to follow that up with option D and make sure that a nurse is going to come and is taking over from you. So we would obviously want to reassure him, but if we just reassure him and then leave him and come back and check later in the day, as a busy doctor, it's likely to be a number of hours until you can get back and check on Mr. Johnson. It might be too late then. If it's 3 or 4 hours later and he's not been able to eat his breakfast, then potentially lunch has been and gone. Has he been able to eat his lunch? So certainly shouldn't just be providing that reassurance and leaving him to hope that somebody does come and treat him. Whatever happens, we want to be taking that responsibility and dealing with the issue ourselves, or ensuring that somebody else comes and takes over and deals with that issue. And that links us to good medical practice and achieving good medical practice, where we focus on the point of making the care of your patient your first concern. So when we talked about what makes a good doctor, this was one of the first points. And if you are a competent doctor, if you are a good doctor, you should be making the care of your patient your first concern. And that means not just leaving a patient without any form of treatment, not just reassuring the patient. It means taking responsibility and ensuring that that patient is cared for by yourself or by a colleague. We also have guidance that relates to raising and acting on concerns. So if we have concerns that, this scenario that we've just looked at with Dr. Sharma, if that type of scenario is happening on a regular basis, and we are concerned actually that patients are often being put at risk and not being looked after and cared for as we would expect, then we have a duty to report those concerns. And although this guidance relates to doctors, if you are a medical student, you also have that same duty, and there should be processes with your medical school that allow you to feed back concerns that you have if you think that patient safety is being compromised. So do make sure once you start on your placements that you know what those processes are, because if you come across an issue and you've got concerns, you want to take responsibility and report those concerns to the appropriate people. So we do have a confidential helpline that can help you if you come across an issue and you're just really not sure what to do. There is a confidential GMC helpline. So this may assist you if you're a medical student or once you are on the register as a qualified doctor. We've got that confidential helpline where you can just speak to us and get some help and advice from us, and we'll be able to talk through the scenario that you find yourself in and give you a bit of help and advice and hopefully allow you to resolve that situation. Also, a flowchart, sort of a guide, if you like, on the GMC website, which again just allows you to talk through the different scenarios that you may find yourself in. So you're in a scenario and it gives you yes or no. It gives you questions that you can ask yourself with yes or no answers and takes you through the flowchart, and you will arrive at a point that it will tell you what you need to do. And that may be that you need to report it to somebody more senior. It may be that you need to contact the GMC. Different options available to you. in terms of resolving those issues. So key points in terms of raising a concern is applying your local protocols. So as I say, for you as med students, you should be aware of your local medical school protocols and guidance that you should follow if you have any concerns. You should be seeking appropriate advice and support, and that can be through the GMC confidential helpline, by speaking to your peers or your colleagues and getting support from them. And also really important that you keep a record of the concerns that you have got, and you make sure that you record any action that you've taken, any concerns that you've shared with people more senior. Make sure that that is recorded, because that's going to be your evidence that you did take the appropriate action. So we're just going to look at a final scenario here, and again, this is now thinking about you as a medical student. So Jasdeep is a conscientious student and is keen to impress his supervisors. He is concerned when the doctor supervising him arrives to work apparently still intoxicated from the night before. Now Jasdeep shares his concerns with a friend from the medical school. But what do you think Jasdeep should do next? So we've got the scenario where his supervisor appears to have arrived at work intoxicated. He's spoken to a friend. Now, what advice, if you were the friend who was speaking to Jasdeep, what advice would you give in this type of scenario? Do we think that we should be having a quiet word with the doctor and explaining your concerns? So let's speak to the supervisor. Let's tell them that we're a bit concerned that they seem to be under the influence. Should we say nothing? This is just a one-off incident. It's the first time that the supervisor's ever turned up at work smelling or appearing to be intoxicated. So let's not worry too much about it. Or should we be reporting the incident to the medical school? So you can see lots of comments coming through here. Yep, so thinking maybe A, but also C, but then the majority are going for C. So how many of you would feel comfortable going for option A? Because I think in this scenario, you could probably go for option A as long as we follow it up with option C and report it. So we should definitely be reporting issues like this to the medical school. But would many of you feel comfortable speaking to your supervisor, one of your seniors, and having a quiet word with them and explaining your concerns? Would anyone feel that would be the appropriate course of action? Yep, so thinking if we've got a good relationship with the supervisor, then we might be happy to discuss it with them. But from my perspective, I think it's probably easier said than done to have a quiet word with your supervisor. If you have got that good relationship and you do get on with them, then yeah, you might want to speak to them about it and raise those concerns. But yeah, if he's under the influence, then it might be might be a difficult conversation to have. He might not like being questioned by you. It's quite a difficult situation. I think what we should do is ensure that we are dealing with this there and then. So we should be immediately speaking to the medical school, and the medical school will give you advice and tell you what to do in this type of situation. Probably want to be speaking to some of our more senior colleagues. So speak to some of the doctors who are also supporting us and make sure that this is dealt with straight away. So we don't want this doctor going on to a ward round or going into surgery, potentially harming patients because they are under the influence. So if we do feel comfortable to go and have that conversation, then that would be the right thing to do, but also recognizing that having that conversation with somebody more senior than you and somebody who is actually responsible for your progress is a difficult decision to find yourself, a difficult position to find yourself in. So certainly report it to the medical school, but inform your seniors and make sure somebody ensures that that doctor isn't going to be treating patients. So yeah, informing somebody else, making sure someone takes responsibility, and reporting that incident to the medical school, because they will be able to help you and give you guidance in that type of situation. I'm a bit conscious of time. So I've got 2 exercises here. I'll let you choose. So do we want to look more at raising concerns, or do we want to look at professional boundaries? I'll go with I think probably professional boundaries might be a good one to look at, because we've talked about the process for raising concerns. So I'm just going to ask you to pick out a couple of. We'll go through them one at a time. So first and foremost, let's start at the top of the list. So do we think it's acceptable for a doctor to send a patient a Christmas card? Is that acceptable? If you are working as a doctor, when you're on placement as a medical student, do you think it's acceptable for you to send your patient a Christmas card? So we've got a few no's coming through. Good point from Alice, I think there. It depends on what the message says. Yep, so it's certainly not the worst thing on the list. So we've got a yes. So in terms of GMC guidance, we don't say yes you can send a Christmas card, no you can't send a Christmas card. We are obviously not that clear, but we are certainly here thinking about those professional boundaries and some of the points that you have made. So it depends what the message is on the card, depends what the intentions are of sending this card, certainly depends on the circumstances. And yeah, perhaps, thinking about, are we giving certain patients, favoritism in different scenarios? So if the doctor and patient have a close bond through a traumatic event, then we might be thinking that's okay, maybe. Would only be appropriate if you otherwise had a relationship with the patient, but then you probably don't want to be treating them. So I think that's a good point. So really, we're thinking here, it's probably not ideal. So you shouldn't be sending you shouldn't be just picking out specific patients and sending them Christmas cards, because that again brings us to the reason for us doing that. Why are you picking individual patients to send cards to? But what you may find is, and certainly a lot of GP practices now, they will just send cards to all of the patients that are registered with the GP practice, just as a nice thing to do, really, a goodwill gesture. But certainly you shouldn't be logging on to systems to access patient details that will allow you to send things such as Christmas cards, because those patients may question how you got their details and why you are sending a card to them. So just have a look at this question. So told not to make assumptions. What is the best way to decide the appropriate answer if you feel there was? So I think if you're not given enough information on this type of scenario, if it was just, should you be sending a patient a Christmas card, I think the answer would be no, really, because you don't have enough information to make that decision. So, if you as an individual doctor really shouldn't be picking and choosing who you send a card to, but it may be, kind of as Alice has said there, it may be that if you're a GP, you just, you give cards out to every patient who comes to see you, and in that case, it's absolutely appropriate. So I would hope in the SJT that you will be given more information around the circumstances, and you would have to decide whether or not in those circumstances it would be appropriate. And it is very much thinking about the meaning behind the card being given and how that is likely to be received by the patient. So, they're the things that we want to be considering, and those, those boundaries that we need to ensure are in place between you and the patient. So I'm conscious of time, so we've probably not got time to go through every one of these. So I'll just give you the opportunity to pick out a couple. So do a couple of people just want to pick from the list ones that you'd like to discuss in a bit more detail, and we can talk about those. So the one about the wine. So we'll go for the wine and the pray, asking a patient to pray with you first. So where's the wine one? Let me find it. How can I not find this? There. A doctor accepts a bottle of wine from a patient. So that's thinking about gifts. Is it okay for you to receive a gift from a patient, whether it be a bottle of wine, whether it be a box of chocolates, a bowl of fruit? Looks like we've got most of the list coming through, so try and move through them as quickly as possible. So I'll talk about the wine one, and I'll go down the list very quickly. So, doctor, if a patient is just giving you a gift to say thank you, so it could be, it could be a Christmas present, could be a patient comes and says, thanks for all the care that you've given me over the last year. Just want to give you a bottle of wine or a box of chocolates. Just want to say thank you, really, for your hard work. Now, most of the time, that's going to be absolutely fine. You can accept gifts as long as the gift is not being given to influence how you are treating that patient in any way. So if a patient is just giving you a gift to say thank you, most of the time that's going to be absolutely fine, as long as it's not an extremely expensive gift, because the places where you're on placement and where you end up working, they will have local policies in place around the value of gifts that you are allowed to accept. But certainly if a doctor gives you a bottle of wine, not going to be a problem accepting that. If a patient gives you a box of chocolates, you're going to want to accept that and share it with the wider team. And that's in good medical practice. You can the very last paragraph talks about accepting gifts, but it's not going to cause you any problems accepting a gift from a patient, as long as it is given and accepted in the correct manner. So we'll just go through them from the top. So second one down, making a joke about the colour of a patient's hair while undertaking an intimate examination is obviously absolutely inappropriate and not something that should be happening. So there is very clear guidance around intimate examinations and carrying out intimate examinations, and the guidance is very clear that you should only be talking to a patient about things that are relevant to the examination that is taking place. That is obviously not a relevant conversation to be having. It's likely to make the patient feel pretty uncomfortable, might offend the patient, might embarrass the patient. So obviously, we don't want to be making jokes, if it is a joke, during those types of examinations. So a doctor bumps into a patient in a nightclub and starts talking to them. Now, again, probably not going to cause you any problems. Obviously, at the moment, we can't be. So it doesn't, making light of the conversation, make the patients feel less nervous. So I think, yeah, you might want to, talk about other things to try and, lighten the mood a bit. So you might talk about the weather. That we like to do that in in Britain a lot. So talk about the weather, talk about what's going on in the news at the moment, maybe. Other things that you may want, other conversational tactics that you may want to use to try and lighten the mood a bit, to make the patient feel a bit more comfortable if they are nervous. But talking about, potentially personal things like that with a patient, I think are likely to make them feel uncomfortable. So if you bump into a patient in a nightclub, just because you are medical students or doctors does not mean that you don't have lives and that you don't go out. And, potentially you might end up working in quite a small community, and, you will see patients that you are treating on a regular basis. And absolutely, as Alice has said there, if you see a patient, then if you just ignore them, you're likely to offend that patient, and it might seem quite rude if you just pretend that you don't know them. But what I would say is, you don't want to spend nights out, or if you go to the theatre or you're out at the supermarket, you don't want to be spending time talking to your patients, constantly. So you might want to just say a polite hello and then move on. So, you can talk to patients outside of the workplace, obviously, but important for your own well-being that you don't become a doctor who is, speaking to patients all the time, and you don't want to be encouraging patients to ask you, things about their treatment or diagnosis outside of the workplace. So it's not going to cause you any issues, but you want to be careful that you don't get into the habit of doing that, and you want to be polite and then probably move on quite quickly. So a doctor borrowing money from the practice manager, again, on the face of it, is not going to cause you any issues. I'm sure we have all left the house at different times and forgotten our wallets, forgotten our purses, left our bank cards at home, not got any money on us. If you're just borrowing £5 or £10 to go and get some lunch or whatever it is that's needed, going to be absolutely fine. The issues that we want to consider there are, what if this is an ongoing process? What if a colleague is asking you, every other day, can I borrow £10, £20? And continuing to do that, then it may suggest there are other issues there. So we want to think about the wider issues that might be at play, but shouldn't cause you any issues just borrowing, a one-off £5 from the practice manager. I'm sure we've all borrowed money from colleagues or friends before when we've been left short. If it's huge amounts of money, then again, it's going to start raising questions. So just thinking, would that not slightly affect the relationship with the patient and doctor? So if we're thinking about the nightclub, then just saying hello and being polite should not affect that doctor-patient relationship. Obviously, you don't want to spend your night out with the patient, and you want to say hello and quickly move on. But I think it's more likely to affect the relationship if you just ignore them completely and pretend that you haven't seen them or you don't know who they are. You're more likely to leave them feeling offended by that. So next we've got the doctor eats a patient's sandwich they've left behind after they've been discharged. So absolutely up to you if you choose to do that. There may be local guidance in the hospitals that you are working that says you shouldn't do that, but it's not going to get you in any trouble with the GMC if you are eating food that has been left behind. Totally up to you if you wish to do that. And we've covered the wine. We've got the Valentine's Day card, which is similar in a way to the Christmas card, but that's you. This is you accepting a Valentine's Day card. So again, it depends on the situation. If this is a young child, if you're working on pediatrics and you've maybe got a 5 or 6 year old child who doesn't really understand what Valentine's Day is, but they just want to make a card and give it you because, they think it's a nice gesture, then you obviously don't want to offend that patient and say no. But if it was a patient who is, maybe a bit older, maybe a teenage patient or an older patient who you are treating, and they feel that they're giving you the card, because they've perhaps got some romantic feelings towards you, and they're expecting things to go further, then you should be trying to explain to the patient why that's not appropriate for you to accept the card, explain the patient-doctor relationship, and don't be, accepting a card that may, give the patient the wrong impression of what could potentially happen in the future. So a doctor asks a patient who is terminally ill to pray with them. There is guidance about this, so you can have a read about it in more detail about those doctor-patient boundaries and making sure we maintain those boundaries. And again, this is likely to be inappropriate. So we are clear that the doctors, you shouldn't be imposing your own beliefs onto a patient. And if you're not sure what a patient's beliefs are, then by suggesting this, you could be offending them. A patient may ask you to pray with them, and then that's a different scenario. That's a decision that you have to make. And there could be scenarios where you know the patient from outside of work, and they go to your local place that your local place of worship, and you would then think it was appropriate. But generally, we shouldn't be imposing our own beliefs onto a patient, and there is very detailed guidance about that, so you could have a read of it in more detail. The last two, so a doctor uses a receptionist as a chaperone. Generally, no, that shouldn't be happening, but there are now more and more circumstances where GP practices are actually training up receptionists, so they have the skills and the knowledge to act as a chaperone. So generally no, because anybody who acts as a chaperone has got to have knowledge and experience of the examination that's taking place. So generally going to be no, but if in the rare circumstances the receptionist does have those skills, then it may be appropriate for them to act as a chaperone. Just get a comment there from Alice. It may make the patient feel more comfortable if they ask you to pray and you do it. So if the patient asks you, then it is a decision for you to make. If you share the same beliefs as the patient, it may be something that you are able to that you feel comfortable doing. But again, it's just about maintaining those boundaries. So are medical students allowed to be chaperones? So it depends on the training that you have had and your level of experience and the workplace that you are in. So the guidance is very clear that really anyone can act as a chaperone. You don't have to be a doctor or a nurse to act as a chaperone. You just have to have the right experience and knowledge of the examination that is taken place. So I guess in theory, you could be trained up in a short period of time to be able to act as a chaperone for maybe some simple examinations, but be very clear that you do need to have that relevant experience and training in order for you to act as a chaperone, because ultimately, if you are a chaperone, you've got to know what's happening during that examination. And if you are watching an examination, you need to know whether the doctor carrying out the examination is doing that correctly. Are they behaving and carrying out the examination in the right way? And if you don't have that knowledge and experience, then you wouldn't be able to say if something wasn't being done correctly. The final point, so prescribing temazepam for their niece, that is something that you should not be doing. So you should not be treating friends and family unless it is an emergency situation. So the guidance is very clear that you shouldn't be treating friends and family. And the reason for that is because you need to be objective as doctors. And if you are treating people close to you, you are not going to be objective. If you're treating your husband or your wife or your mum or your dad or your son or your daughter, you are going to treat them differently than you would do any other patient, because you have that emotional connection with them and you care for them and you want you are going to want to do more for them than you perhaps would any other patient who's just walked in off the street. So we shouldn't be treating friends and family unless it is an emergency situation and there are no other options available. So certainly shouldn't be prescribing that type of medication to somebody close to us, because we won't have had access to their medical records. We won't know about their medical background and whether or not this medication is required. Yep, so even if you are working privately, whether you are a doctor in the NHS, whether you are working privately, the GMC guidance still relates to you in private practice, and you shouldn't be treating friends or family in private practice, again, for the reasons that you're going to find it difficult to be objective. Can see lots of comments coming through, so I'll just try and catch up on them. Yeah, so certainly you want to try and keep the religious elements separate from any form of treatment. And that's sometimes going to be difficult if you've got patients who are very religious and want to share their thoughts with you. But you just need to be sure that you don't offend the patient in any conversations. And then, yeah, the issues around treating family members is exactly because you're likely to treat them differently than you would to other patients, and that's absolutely key, really. So I think the point there, you would try and do the best of your ability for every patient and treat them with the same care. I think that is an ideal way of looking at it, but we have to be honest, really, and in reality, if you think about somebody who is close to you, so I don't know if you are married, if you've got children, if you think about your parents, if you are treating somebody who you are extremely close to and have got that emotional attachment with, it's just human nature that you would treat that person differently than you would to a patient who you've never met before, and you would. Yeah, exactly. Unconscious bias, even if it's not intentional, then you would treat them differently just because that is human nature, really. So yeah, ideally you shouldn't be seeing friends or family, even if it's within a G. So if you're working as a GP, for example, you should be asking your friends and family to ideally be registered with another GP. It's not always going to be possible, so the guidance doesn't say you must do that. It says that you should where possible. And again, the reason being because you are, if you're treating family members, there you go, exactly the points that are raised, that that may put them off coming to the doctor. They may not want to come to you, and they may not want to share that personal information with you because of that close relationship that you've got. So it works both ways, that so it's not against the law to operate on a family member, but it's against GMC guidance unless it's an emergency situation. So you would be breaking GMC guidance if you were to operate on a family member unless it was an emergency situation. So just a point there. So as medical students, this would apply, and you wouldn't be allowed to attend consultations of a patient you know. If you are attending in a role as a medical student, so if you're on placement and you go into a consultation and actually you know the person in that consultation, you want to make the doctor who you are working with aware of that, and ideally you don't want to be in that consultation, because as we've said, it's likely to make the patient feel uncomfortable, and they may not share information with the doctor because they know you, and we certainly don't want to put a patient in that situation. So can a doctor refuse to treat a patient? You can refuse to treat a patient, and there is information on the GMC website about refusing to treat patients. And you can, as long as you are not going to, as long as a patient isn't going to come to harm, you can choose not to treat a patient. But not really got time to get into the ins and outs of that. There is information on the website around those professional boundaries and managing those. So consequences of breaking GMC guidelines. So different levels of that, and it obviously depends how you have broken those guidelines. So first and foremost, if you're not following GMC guidance, it's going to cause you issues with your employer, with your medical school, whatever level you may be at. It's going to lead to local investigations and local issues with your performance. If you continue to not follow the guidance, it could ultimately lead to referral to the GMC and investigations being carried out, and different outcomes to those investigations. So again, you can have a look on the website at our fitness to practice procedures and how they are managed. Final question before we wrap things up: as a medical student, how would I react to a patient that's aggressive and feels uncomfortable with a medical student being present? So I think in any scenario, a patient has a right to refuse treatment, and if a patient doesn't feel comfortable with you being there as a medical student, that should be managed by the doctor you are working with, and they should be talking to the patient and explaining why it's really important that you are allowed to sit in on consultations and observe those, and at times be involved in those examinations. But ultimately, if a patient refuses and says, actually, I'm just very uncomfortable, then it should be managed by the doctor who you are working with and through the placement that you are on. So yeah, they ultimately do have the right to say, actually, I don't want this person present. And I have been out and shadowed doctors myself previously. Every time there's a conversation with the patient, explaining who I am, why I'm there, and giving them the option, if they're not comfortable, that I can step outside and not be part of that discussion. So that's how it should be managed. So guidance that we've talked about there is all available on our ethical guidance page on the website. So do go and have a look and read the guidance in a bit more detail in terms of the scenarios that we have talked about. And we've got an ethical hub where you can watch different scenarios, you can look at case studies, and you can test your knowledge and understanding. So you can look at how you would act in those different situations. And there's just a selection of them that might be able to help you out. And then just a bit conscious of time because I've got a session coming up in a few minutes. But if you do have any questions, feel free to pop them in the chat box, or do take my contact details and feel free to contact me separately if you want to discuss anything that you haven't got time to discuss today, or individual issues that you don't want to share with the group. Feel free to contact me separately. If there are no other questions, I'll just thank you all for coming along to the session. Really appreciate you joining in. Hope you found it useful. There were some really good conversations there, so do appreciate you getting involved and asking those questions. But good luck for the future. Hope that your the rest of your time in medical school goes well. If you are at med school, best of luck for the future for all of you. And again, running some sessions later on, so may see some of you in those sessions in the next hour or so.